Kia ora, talofa, Malay. You're back with me again. I'm going to give the talk that started really with the discussion with Dr. Ana Kaloto, actually, but work that we had better start, and the Ministry of Pacific People got together and decided we wanted to work together on something, and the thing that we decided on was mental health in the Pacific population. And talking about Dr. Ana, about different Pacific frameworks, we're focusing on one here, the Divide framework, the Cook Islands framework, which is different from the three that we mentioned before, and the Kakala model, which is the fifth one.
There's a Fijian model too. There's one Vanua model.
I think Ata and Anita are joining.
Ata and Anita joining, fantastic. So yes. So as I foreshadowed here, this was work that we done as part of the Better Start Natural Science Challenge, working together with the Ministry of Pacific Peoples to answer a big data of sorts. I'll get to the data that we used. Question of interest to the Pacific population and particularly the Ministry of Pacific Peoples. And what we focused on is focusing on mental health. Okay. Gorgeous day in Dunedin it was that day, unlike today here in either Auckland or Wellington. This is a planning meeting that we had for this research, and that's most of the group there, myself, Anita, Ata, Rose Richards, who works with Jesse Kokaua, and helped us on that day, but isn't part of the ongoing team, and who wasn't there that day was Troy Rohi. Who's also did a lot of the work actually on the literature review for this project. And just jumping ahead, we're finalising a report for this now that has been through peer review, and we're just getting to the point where it is about to be published, I think, and would like to launch it at some point. Okay, so as I said, it's a partnership between Ministry for Pacific Peoples and the Better Start Big Data team to explore the characteristics of Pacific people's mental health. And one of the reasons we wanted to do this is it's the first time since Tiro Hinengaro, which was the mental health survey of New Zealand, peoples generally, that there's been an in-depth insight into mental health at a population level for the Pacific population. And our base data here was access to the integrated data infrastructure, hence kind of making it big data, but it's a survey. It's the New Zealand Health Survey. We want to focus on the New Zealand Health Survey differently from the previous two presentations and the presentation after this, because it gets you at mental health problems in the community, not just who sought services for mental health. And so we want to explore Pacific mental health, looking at different Pacific communities and looking at what the correlates were in those different communities for different mental health problems in both children and adults. Meeting Better Start's wider objectives, we have an interest in resiliency, and we have interest in healthy weight, which we didn't work in here, but in education, and we looked at associations with education and what we were doing. And the ministry's the Langafau goals, which I think, in the interest of time, unfortunately, sorry, Dr. Ana, I think I might have cut out the presentation. So, but if you're interested, you can talk to Dr. Ana about this. Using the IDI again. So the disclaimer is there. Okay, no, I didn't cut it out. How sensible of me. For the Langafau goals, thriving Pacific languages, cultures, and identities, prosperous Pacific communities, resilient and healthy Pacific peoples, and confident, thriving, and resilient Pacific young people. So we are focusing on goals 3 and 4 here for this research. And as I mentioned before, the Better Start Natural Science Challenge, of which I'm a part, is focused really on 4 theme areas, substantive theme areas: healthy weight, resilient teens, and the resiliency part is what we're focusing on here, successful learning, and vision mātauranga. And the big data theme, just to see where we fit, we sort of sit across the 3 themes above that, really, to answer questions using whole population data mainly of interest to the teams, the research teams working on those other 3 areas. So as part of that, we had a key objective to answer a big data question in relation to relevant to Pacific peoples, and we took the view that it wasn't for us to come up with that question. We would speak with groups who have an interest in the data that we know how to analyse and see what was in interest to them. And so settled with the Ministry for Pacific Peoples, and that's how this sort of came about. So focus on resiliency while investigating associations with learning through the education data. Less of a focus on healthy weight, but there's been lots of work that the big data theme has done in that area, including on Pacific. Okay, so this is repeating a little bit of what you've seen already, but Pacific population, just under 400,000 in 2018. Be interesting to see what's going to happen with the latest census, whether you tick up to the 400,000. And that's the groups there. As was alluded to earlier, the Samoan group is the largest group, followed by Tongan and Cook Island Māori, and lower numbers further to the right there. 41% are multi-ethnic. That means, just picking up on Dr. Anna's point from my earlier talk, that they identify with one Pacific ethnicity, but also either another Pacific ethnicity or a non-Pacific ethnicity as well. So it's a heavily multi-ethnic population. I can't tell you what it is for European, but it's in the teens, I think, and for Māori, it's slightly up 50%. Median age, as Zanetta highlighted, overall for the Pacific population is about 23, for different Pacific populations, lower still. Think about this for a second, what this means for the upcoming election in a couple of weeks' time, where the Tuvaluan population, for instance, half the population are below the voting age. And so expecting those above the voting age to do all the representation of them, and many of those, or some of those at least for many reasons, will not vote. 2/3 in Auckland, 2/3 now, thank you, Dr. Anna, born in New Zealand, and that's higher amongst the younger Pacific population. High unmet health need, socioeconomic challenged population, greater than half of the population live in the bottom 2 deciles of deprivation. In terms of what's known already about Pacific mental health and where we thought we needed to update things, early studies, and we're talking from the 1990s here, indicate a high level of psychological distress in the Pacific population. And this was related to a little bit immigration experiences, coming to the country and experiencing poor living conditions, discrimination, and adaptation to a new set of cultures, contribute to this mental and physical distress. But diagnosis is lower. So despite the fact that there may be a high amount of distress or a high number of symptoms, getting a diagnosis in the official system tended to be an issue, where admission rates, say, were half of non-Pacific population. And then this survey was fantastic. It's only been done once. The Te Rao Henengaro that Jesse Kokaua worked on, I believe, of 13,000 odd adults, and a oversampling, a decent oversampling of the Pacific population, so 2,300, nearly 2,400 Pacific people. So higher psychological distress, higher alcohol and drug use, but lower service access. And they, in terms of why that might be the case, this wasn't directly from the survey, but other research that has gone on either since or before that. One of the things that's been proposed is that there is unfair treatment in health settings, and that may put Pacific off gaining treatment where they need it. There's access barriers, and the health literacy point that I made earlier may be an issue. And then there's also, particularly in relation to some of those issues, are issues for other health problems as well, but particularly relating to mental health, there is issues with, in some cases, stigma associated with mental health, and also preferences for different models or modes of treatment that don't involve going to a health professional. And what has been found also is high rates of distress diagnosis amongst New Zealand born versus Pacific born population. So what we wanted to do, using the New Zealand Health Survey, is answer a series of questions. Firstly, do Pacific people with mental health conditions differ from the overall Pacific population in terms of their demographics, in terms of their age, ethnicity, gender? do any of those factors, or flipping it back the other way, do any of those factors predict mental health, having a mental health issue? Do Pacific people who deal with issues related to mental health differ in their education status, financial situation, household overcrowding, and deprivation from the overall Pacific population? There's a trends question, as similar to the one that was raised before. What are the prevalence trends for adult and child mental health outcomes from 2011 to 2021 for the Pacific population, or for Pacific populations, I should say? And if you look at that, you can get towards an answer to the question, is there evidence for an impact of COVID-19 on mental health in the Pacific peoples living in New Zealand? Those are what we wanted to answer. And we used a tailored Te Waiwai research framework. So the Te Waiwai research framework was originally developed, I think, in the education space by Te Moana Maua Hodges in 2018. That proposed 5 steps. Then Jesse Kokaua said, he thinks, and others think, that this can be modified for quantitative research, particularly whole population quantitative research. So that paper there, which has got Troy on it as well, develops the Te Waiwai method for quantitative Pacific health research project using the IDI. So similar to what we're doing here, although we're focusing on survey data, but again, using the IDI. And I should say, there's a meeting here, happened here in Wellington, I think, to come up with the final 8 steps that were developed for this particular project. So we can call that Te Moana Maua Hodges and Jesse Kokaua, December 2022, because that's when they met and came up with the 8 steps, which are these here. And I wish I could see the top of that. Here we go. Okarama, is that the first one? So basically planning the vision for the research. So that early work was done with Dr. Anna and others, and with Anita and Ata and Jesse along. So shaping the project and forming the team. Okaruru, so the design and methodology, selecting the appropriate frameworks that we want to use, what IDI datasets that we want to use. We're focusing here on the New Zealand Health Survey. The Patoki, so sorry, I skipped one. The Akaruru, the selection of appropriate frameworks and datasets. Then the Patoki selecting the indicators and variables that we want to construct. The analysis and review of the analysis, the Mumu, the Tui, interpretation and of the data and the key findings. That's when we start discussing things with people. And the Akamania, verifying and summarizing the findings. That's through the next one through the peer review process, the validation of it. And the final one, which we're getting to now, the order, is the sharing the findings and the recommendations with the Pacific community. So as I say, we're finalizing the report now. We've got it the way we like it, I think, but it's just going through its final stages. Okay. Patoki, sources of data. So access to the integrated data infrastructure, which is Zanetta covered before, integrated set of data sources from different government agencies, and also some surveys are able to be analysed at the individual level, so you can link people from their survey responses to their education outcomes, for instance. And with link to census variables that we wanted to look at as well. For the survey is available in the integrated data infrastructure from 2011 to 2019, but not beyond that. So it didn't actually enable us to answer the COVID question using those data. So we jumped out of the IDI to answer that question, where we used trends data from the New Zealand Health Survey Data Explorer, which anyone can get to just from that link there. For adult populations, we looked at doctor-diagnosed depression and anxiety and self-reported psychological distress. We focus on those because those are the things that we're focused on in the New Zealand Health Survey. It's a survey that covers lots of aspects of health, not just focus on mental health. So there's a relatively narrow range of things that we wanted to look at. But for Pacific children, there was also various doctor-diagnosed things, such as doctor-diagnosed emotional behavioural problems or ADHD, but they were reported with such low prevalence that they weren't really able to be looked at, which But what is also in the New Zealand Health Survey is the behavioural assessment tool called the Strengths and Difficulties Questionnaire, which runs through a series of items in different areas of emotional well-being and essentially assesses children on the extent to which they're having difficulties in those areas. And those data are available from the New Zealand Health Survey, not throughout the period, but at various years of the New Zealand Health Survey. The New Zealand Health Survey is kind of run continuously now, but as a series of annual surveys. So 2012, 14, 15, and 16 are the ones that had the Strengths and Difficulties Questionnaire that we could analyse data for. So these are the numbers we're able to work with. A couple of things to note here. One is that the New Zealand Health Survey is big, 113,000 people, but because it's got only representative numbers of Pacific adults and Pacific children, you get relatively small numbers, far fewer numbers than the Te Reo Hinengaro survey, which oversampled Pacific, and I'll come back to that issue. For the ODI data, the table on the right represents those who did the New Zealand Health Survey and also said, I'm happy for you to link my data to other data sources, and those are only those cases were put into the ODI and could be linked to other things such as the census. So we get slightly smaller numbers still for the Pacific population. Okay, so yes, so depression, anxiety, psychological distress in adults, and the 5 Strengths and Difficulties Questionnaire scales that we looked at. We looked at them as continuous scales, so you get a score from very low to very high and anything in between. Emotional problems, peer problems, hyperactivity, inattention, cognitive problems, and a strengths one, which I guess is why it's called that. It should be lowercase strengths and uppercase difficulties, given the balance. It's prosocial behaviour. Okay, so in terms of what we wanted to look at for each of these things, and I'll rush through this a little bit because I know I'm digging into question time a little bit, is age, ethnicity. Those were the Pacific ethnic groups and non-Pacific ethnic groups among Pacific people for whom we had enough numbers to look at. And people could belong to more than one. Gender, place of birth, as I said, 2/3 of the Pacific population now were born in New Zealand, and that's a high, I think it's 90%, 90% in children. And DHB still existed when we did this work. We started doing this work, so we grouped them into 6, either DHBs or conglomerations of DHBs. And then socioeconomic factors, education, income, labour force status, whether or not they live in an own home, overcrowding in terms of the number of people per bedroom, and level of deprivation. Okay, so what were the demographic correlates for adults? In terms of depression, it affects about 24,000 Pacific peoples, 1 in 12, which is a lower prevalence than non-Pacific population. Seems to be slightly increasing over time, about a 0.2 percentage point increase per year. And this is the next point, about 50% more common in women than men. That's true of depression in non-Pacific populations as well. Twice as common New Zealand born than overseas born, and highest in middle adulthood. For the non-Pacific population, not that we did a direct comparison, I think it's probably highest in 25 to 34, maybe even lower. Anxiety, kind of similar trends. It's increasing more over time by about 0.7 of a percentage point over time. So every, every 10 years, it'll go up by 7 percentage points. Overall effects in 2021-22, affects 1 in 11 Pacific people, again lower than the non-Pacific population, again more common amongst women and amongst those born in New Zealand, and highest in the sort of middle-aged group for anxiety. Psychological distress, and why I like the comparison of psychological distress, which covers depression and anxiety a little bit, is that depression and anxiety is, has a doctor ever told you that you had these things? And for a doctor to ever told you that you had depression and anxiety, you have to have gone to a doctor. Whereas psychological distress is a series of questions about how you're feeling now. And you can rate people as high on that. So high psychological distress affects 1 in 7 Pacific people, higher prevalence than non-Pacific. So when you look at something that's based on symptoms, rather than something that is based on having a doctor told you that you have stuff, you actually see higher rates in the Pacific population. Increasing again, more common in women, no difference when you look at symptoms between New Zealand born and the overseas born, and similar rates across ages, interestingly. Maybe we'll just click through to all of these. In terms of socio-economic correlates, no education gradient, so a gradient across education groups for depression and anxiety. Lower income, however, more likely to have doctor-diagnosed depression and anxiety. Depression more likely amongst those who are unemployed, lowest amongst those living in overcrowded houses, same as with anxiety. And no deprivation gradient for depression, but for anxiety, highest amongst those living in the least deprived areas. So highest amongst those Pacific people living in the most affluent areas. Is that an access issue? Hard to know. Can only dig so far, but that's one possibility. Psychological distress decreases with increasing education. So the lower education, people who are in lower education groups are more likely to have high psychological distress, associated with lower income, amongst the unemployed, amongst those living in rented homes, and no deprivation gradient, interestingly. I know I'm going through this quickly, but I need to move along a little bit. For the things we looked at in children, again, maybe I'll jump through to all of these. So we've got each of the 5 scales in a different box here, and then the total problems, which is the everything added together except the pro-social one. Emotional problems not changing over time, but increases with age. Nothing's changing over time. In fact, there's no evidence that child behaviour problems have increased over the 4 years we're able to look. Peer problems high amongst boys, seems to be higher amongst children living in counties Manukau, DHB. Hyperactivity also high amongst boys, as is conduct problems. Those are things that in my language are known as externalizing problems, which tend to be higher amongst boys, than internalizing problems, emotional problems, which tend to be higher amongst girls, although there's a puberty thing that kicks in there as well. Hyperactivity higher amongst very young children, as with conduct problems, whereas pro-social problem higher amongst girls and tends to increase with age. And for total problems, you're seeing more or less what you expect from what you're looking at with the emotional conduct, peer and hyperactivity problems, not changing over time, overall higher amongst boys, and you get higher rates in very young children. No deprivation gradient with emotional problems, but you do see that with peer problems and for rented homes with peer problems. Deprivation trends with hyperactivity as well, and with total problems, and the opposite trend with pro-social. So whereas all the problem behaviours tend to be increasing with deprivation, the pro-social behaviours are decreasing with increasing deprivation. Okay, did COVID impact Pacific mental health? What I've got there is the overall prevalence rates for the period spanning before and after COVID began, 2018, 2019, 2020, 2021. What do you reckon? So I don't think there's much going on with depression. Anxiety looks to be quite a trend going on there, and then psychological distress, a bit of bounce. But when you put on the confidence intervals, suggesting that the rates are somewhere in those bars somewhere, there's no evidence that there's any change over time, which is a couple of things. One, maybe there was an impact of COVID. Two, maybe there wasn't an impact of COVID. Two, if there was, we're unable to detect it because we don't have the power to do so. And yeah, so it speaks to, I think, a slight underpowering point from a quantitative point of view. So summary of findings. Lower prevalence of depression and anxiety as diagnosed by a doctor, but higher prevalence of self-related psychological distress amongst the Pacific population. Is this an access barrier thing? This is consistent over 30 years of research. This was picked up from the earlier research. Also, dovetails with some research that Steph led a couple of years ago looking at depression and pregnancy. When you compare medication for depression and pregnancy and a depression scale, you see completely different findings. With specific lower using medication, but higher with symptoms. Socioeconomic correlates largely as expected, although affluence sometimes associated with higher rates of doctor-diagnosed depression and anxiety. Again, is that a better access thing? Hard to know. New Zealand born report more doctor-diagnosed depression and anxiety, may mean better access because they don't report greater number of symptoms. Child behaviour, steady over time. I'd say demographic and social patterns, what I mean by as expected. As I don't think there's anything different going on in the Pacific population as you would see in the non-Pacific population, from my understanding of it, at least. No evidence for a COVID impact, but not well powered to detect one. Okay, so clearly there's Pacific people who are experiencing problems with mental health, and if the psychological distress findings are something to go by, there's a large number of them, and they're not getting the treatment that they need, suggesting that maybe this is a workforce issue, and that may have policy implications. One thing that as an analyst I picked up on is there are implications of specific data collection and research. New Zealand Health Survey is not well placed to investigate correlates or trends of low prevalence outcomes, generally, and low prevalence outcomes amongst smallish population groups. There's a statistical solution to this, in my view, or statistical design solution to this. Oversampling could address this, which will cost more, but in my view will be a heck of a lot cheaper than a devoted Pacific mental health survey, or a devoted full population mental health survey, as was run 20 years ago now. So something I think to consider. Sorry for that, was a bit of a whirlwind run through that, but thank you very much, Maitaki. Thank you.
I wanted to know, what is it that to be born in New Zealand, it increases or the chance of, like it's twice for anxiety and depression, it's twice for those Pacific children born in New Zealand?
I mean, again, the short answer is I don't know, and it's not something that can be gleaned very easily from the data that we analyse. This is where you need the authors of the world to, or others, to go out and do some in-depth interviewing. My biases are towards suggesting it's an access thing. So I think it could be several things. So it could be an access thing. It could be as going picking up on earlier research. Could be to do with greater stigma in Pacific populations born or Pacific peoples born overseas, or a preference to keep it in-house, literally, like within you, asking people within your own house or going to non-health people who aren't health professionals, ministers, for instance. So not something that we can get definitive answers on, but I think there are various possibilities.
Just a thought on that too, and not familiar entirely with the literature, so I could be wrong, but I believe that this is something that's been seen in other ethnic groups as well, where it's second-generation immigrants have higher mental health.
Yeah, right. Good point.
Yeah.
Yeah. So that doesn't point to an answer, but it does point to it being a generic issue.
Potentially.
Yeah. Good point. Thanks, Steve. Anything from the chat, Steve?
There is one. Is it correct? The ethnic groups included in this study were only Polynesian and European. Does that mean the high levels of mental health in your previous presentation for Fijian populations is excluded from this analysis? So no representation of Melanesian peoples.
No, Melanesian, well, it's the Pacific population.
Mm-hmm.
He looks in the air and thinks about how the New Zealand standard classification of ethnicity, and Melanesian is classified. Melanesian is classified within Pacific populations. Mm-hmm. Yeah, so Melanesians will be in there, including Fijian. So no, so it was everyone who identified with at least one Pacific ethnicity, including Melanesian ethnicity. Mm-hmm. And they could also have identified with Maori or European, which is why those groups are in there. So those groups are Pacific who are also European and Pacific who are also Maori. Sorry, I didn't repeat the question. That is, are Melanesian, other Melanesian populations included, or is it just the groups that are listed there, as well as European and Maori?
Yeah.
Yeah. Thank you.